Welcome to this GSA Momentum Discussion webinar titled Anti-Amyloid Therapies for Alzheimer's, Practical Considerations and Best Practices. This is the first of three in a series of webinars addressing different aspects of delivering anti-amyloid therapies for the treatment of early symptomatic Alzheimer's disease. This series is developed by the Gerontological Society of America in collaboration with the Alzheimer's Association with support from Lilly. My name is Jen Pettis, and I'm the Director of Strategic Alliances at the Gerontological Society of America, and I'm pleased to serve as a moderator for today's session. Before introducing our panelists, I'd like to share a few housekeeping items. Please type your questions into the Q&A box at any time during the webinar. We'll have a question and answer session in the last few minutes of our program today. Our program is being recorded today and will be available on demand on GSA Enrich by the end of today. And your feedback is important to us. Please complete the evaluation in GSA Enrich following the webinar. I'm delighted to introduce our expert panelists today. Dr. Armin Magamian is a cognitive neurologist at the Ray Dolby Brain Health Center, which is part of the California Pacific Medical Center and Sutter Health in San Francisco, California. Dr. Magamian is the medical director of the center and leads a multidisciplinary team of physicians, nurse practitioners, neuropsychologists, and social workers in the evaluation and treatment of patients with cognitive impairment. The team at the Dolby Center has pioneered a dyad care model which embeds a social worker into the treatment of the patient, providing support for families and care partners throughout the disease. He also heads the clinical trial program at the Dolby Center focused primarily on treatment trials for Alzheimer's disease and early diagnosis. Dr. Magamian completed his graduate training at UC Berkeley, MD and PhD trainings at the University of Pennsylvania, and neurology residency and fellowship at UCSF. And Dr. Paul Schultz is the Rick McCord Professor of Neurology and the Humphrey Family Professor of Neurodegenerative Diseases and the Director of the Neurocognitive Disorders Center at the McGovern Medical School of UT Health, Houston. Dr. Schultz specializes in neurodegenerative dementias, concentrating on Alzheimer's disease and related disorders. His research focuses on illuminating the processes underlying dementia and risk factors for it, developing tests to diagnose dementia earlier, and pursuing dementia prevention strategies. He also focuses on the development of innovative treatments for these conditions, including single, multi-site, and pharma-sponsored clinical trials. These studies investigate the efficacy of therapies aimed at slowing or halting disease progression. He's a leading expert in dementia care and is recognized for his commitment to improving patient outcomes through both research and clinical practice. Thank you, Dr. Schultz and Dr. Magamian, for joining me here today.
Pleasure to be here.
Wonderful to be here.
Thanks. Before I get us started with today's discussion, I want to highlight that GSA has a significant number of freely available brain health resources, including our flagship brain health resource, the GSA KAER Toolkit for Brain Health. It's available on geron.org/brainhealth or at KAER, Early and accurate diagnosis of mild cognitive impairment or MCI or dementia, including Alzheimer's disease, is crucial. This timely diagnosis empowers individuals to plan for the future, better understand their condition, and potentially slow disease progression through lifestyle changes, access vital support systems, and determine with their healthcare provider and family if disease-modifying treatments are appropriate. Dr. Schultz and Magamian, I'm so pleased to have this opportunity to talk with you both today about these new treatments and learn how you implemented programs to administer them in your health systems. And Dr. Schultz, I'd like to start with you by just asking, what are the currently available anti-amyloid therapies for Alzheimer's and how those function?
Yeah, really good question. So I think the audience may need to know sort of the big picture real briefly, that amyloid deposition in the brain is the first step in the process. Amyloid starts out as single molecules that clump together to eventually form plaques. And then after that, tau protein inflammation and other things happen. So amyloid is the initiator of that, hence our initial focus on anti-amyloid therapy to kind of cut off the head, so to speak. The anti-amyloid therapies that we have now, two of them, are ingenious in the way they work. And what I mean by that is they're actually antibodies. So we all go get our flu shot. We make antibodies against a virus. Virus shows up in my lungs because someone coughs on me in clinic. My antibodies attach to that. They turn on my white blood cells, my immune system, and my immune system gets rid of the bacteria, viruses, etc. This is exactly the same here, except the antibodies attach to amyloid plaques in the brain. They turn on the person's own immune system, which over the next 18-ish months or so managed to get rid of most of the plaques in the brain. So to answer your question, we have two treatments now that are FDA approved. They've gone through all of the necessary studies, and they work by attaching to amyloid plaques in the brain, turning on our own immune system, and getting rid of them.
Dr. Magamian, what does the availability of these amyloid targeting monoclonal antibodies for the treatment of Alzheimer's mean to you as a clinician?
So, this is a huge step forward in the treatment of Alzheimer's disease. And the reason that these medications are a major step forward is that they are the first set of therapies that actually slow the progression of the disease. So if we take a step back, we've had treatments for Alzheimer's disease for 30 years or so that tended to work on kind of optimizing brain chemistry. So many of the people on this call will have heard of donepezil or Aricept. There are other similar medications such as rivastigmine and Exelon that sort of boosted people's brain function a little bit by increasing a chemical in the brain called acetylcholine that got a little bit better attention, a little bit better memory, but they didn't change the rate of progression. So if you think about Alzheimer's disease as slow change over many years in cognition, like memory and function, what these older medications did is they sort of boosted people up a little bit. They created a parallel line that was modestly kind of a boost upward, but they didn't change the slope. All right. And so what these new medications do is instead of boosting people modestly, they slow the progression. And so they don't, it's also important to note that they don't reverse what's already going on. They don't make people better. They also don't stop the progression of the disease, but they do significantly slow the progression. And really the goal of treatment is to keep people where they're at for a longer period of time. And this is really borne out in the data, particularly the earlier we intervene, the more likely patients are to stay at these earlier stages. So what does that mean for me and what does that mean for the patient? That means for people that are in these mild cognitive, in the mild cognitive impairment stage, which I like to term as the annoying memory symptoms that people are able to adapt around, it can keep them there for a longer period of time, meaning that they have more time to enjoy with their family and more time to, go and travel and enjoy their lives, and really pushing those later stages of moderate to severe dementia, which is when patients really need a lot of help at home. They start not recognizing family as well. And frankly, just the disease is much more impactful on the patient and their family in those later stages. And it pushes those later stages down the road. And so for me, it's exciting because we're slowing the progression of the disease. And I feel, and the data would support, really significantly impacting their quality of life by keeping them being patients in these earlier stages for a longer period of time and kicking down those later functional declines further down the road.
And I'd like to ask you both this next question, and that is, why was it crucial to make these treatments accessible in your community? And Dr. Schultz, I'll start with you.
Yeah, this is a really unusual circumstance in healthcare in that because Alzheimer's is age-related, the majority of our patients are over 65. And so thank goodness, all of them pretty much in my clinic, and I'm sure Dr. Magamian's, have Medicare. And Medicare is actually the best insurance out there. The under 65 crowd we have to work with and figure out what we can do. And there are programs we have to try to get people involved in it. The Advantage plans are a whole separate issue. But I tell clients here, between 1 and 12 weeks, we can usually get you on one of the medications that we have. The biggest stumbling blocks, Jennifer, are actually not the financial right now. The biggest stumbling block is availability and knowledge. What I mean by that is that the lack of awareness by non-neurologists or even some neurologists of the availability, the lack of awareness by patients so that they don't necessarily think to go to their doctor. They figure, oh, there's nothing can be done about it anyway. No point in going. So seeing people, later than we would like to see them is a big issue. And on the neurologist side, giving an infusion is something some of my colleagues have done. Our MS colleagues have done that, our neuromuscular colleagues, but the rest of us in neurodegenerative diseases have never had something like this. So we don't have the infrastructure for that. What I'm getting at is that between all of these factors, less than 1% of all people in the United States that qualify for the drugs are actually on them. So 99% are still going along at whatever rate they were going to go along with just Aricept and Namenda in their treatment. And the rest of them are uh, going along and progressing inexorably. Time is brain. My stroke colleagues have always told me that. And now in our area, I say the same thing. Time is brain. Come in sooner, be seen sooner, get started sooner. And that knowledge is really one of the biggest barriers we're facing right now, Jennifer.
Okay, thanks. Dr. Magami, the same question for you. Why was it important to make these accessible? And what have you done to help increase that accessibility?
Yeah, I completely agree with Paul. And I think that's why we're both here today on this podcast, to try to improve availability and knowledge about the future of treatment. I came into this field as a cognitive neurologist because I think the brain is the coolest organ in the body, and it's the thing that really makes us human. And the downside to these degenerative diseases is that as people's brain degenerates, it really impacts their quality of life and the things that most people really, really value about themselves. And if there is something that I can do to keep people in these stages earlier for a longer period of time and enjoy their family and quality of life, I'm going to do that. And I'm highly motivated to treat patients. For many years, we have not had these available therapies, and these diseases are devastating, and they're incredibly prevalent, right? I would challenge anybody on here that, this is clearly a selected audience, but you pull anybody off the street and somebody knows somebody with dementia, and that probably means that somebody knows somebody with Alzheimer's disease. This is an incredibly common disease, and we need to improve awareness because there are things to do about it. And the availability is going to be a slow rollout for all of those reasons that Paul brought up. This is a big shift in how we approach this disease, both in the logistics of how we run our clinics, but also in the perception of this disease by the public. So I'm motivated by my patients for the availability of this because it is clear that these medications work and slow the disease down. The data that we're seeing after 3 and 4 years for both lecanemab and donanemab are incredibly encouraging, that we're continuing to see divergence from placebo and more time saved, particularly for those at the earliest stages. So availability for me is because we want to provide access to people. One of the things that I try to tell all of my patients, our job as physicians is not to get people onto medicines, but our job is to open the door. And so what we're trying to do is tell people their diagnosis and their treatment options, A versus B. Like, if people hear about these medications, they hear about the risk, they hear about what is involved, which I'm sure we're going to get into, in getting onto these therapies, and they say, look, that's not for me, more power to them, because I think that I'm really just glad that those people made that decision for themselves. And it's not the right thing for everybody, but if we don't evaluate people and we don't get them to that point where they're able to make the decision, then the system is making the decision for them. And I think that that's fundamentally wrong. We screen for all sorts of things like cancers and blood pressure to improve people's quality of life. And now is the time to really start thinking about screening for cognition. This idea of, oh, it's just, I'm getting old, is not an excuse anymore. And one of the happiest moments I have in clinic is when I evaluate somebody that has very mild changes in their cognition. Maybe it's Alzheimer's, maybe it's not. We have the tools not only to tell somebody that they have it, but the tools to tell them that they don't have it. And so my happiest day is when I can say, look, you don't have Alzheimer's disease. Your MRI looks pretty good, looks normal. Maybe there's a little vascular disease. You don't have Alzheimer's disease. The likelihood of this getting significantly worse is quite low. And, come back to me if things get worse. So time is of the essence. I agree with everything Paul said.
Great. Dr. Schultz, what criteria make a person with MCI or Alzheimer's a good candidate for the new treatments, and for whom are they not recommended?
Yeah, I kind of divided in my mind the way we think when we see someone in clinic. First of all, clinically, we want to make sure they're kind of early. There's a lot of quizzes that we give. People might have heard of MMSE, MOCA, that kind of stuff. And we have kind of early, middle, late, and we look for the early folks. We also want to make sure when we see someone in clinic that they don't have another reason for their cognitive issues. Sleep apnea is real common, depression's common, etc. They can look very similar. So first of all, we want to see someone early who doesn't have another cause. We also do blood work to make sure it's not another cause. B12 deficiency, low thyroid, those are fairly common, so we check those. We want to make sure someone's not on a blood thinner. It turns out that we see little microbleeds with some of these meds, and we don't want a microbleed to become a bigger one. So we've kind of decided as a group not to put people on these meds if they're on a blood thinner. And then we get an MRI. Part of it is to make sure it's not another cause. And the second is that we've learned nowadays to look for a bunch of different things on MRIs that allow us to give the drugs more safely. In other words, there are things on there that will say, oh gosh, no, when we see that, that's not a good person to put on it. For example, if they already have a bunch of microbleeds, if they have an aneurysm, if they have an AVM, we don't want those kind of things to get in the way. And then we also follow people with MRIs and look for other things during the treatment. And finally, the last step is that if all of that stuff is good, then we say, well, the target of our drugs is amyloid. So we want to be sure that someone has amyloid in the brain. And we can do that a number of different ways. Spinal fluid and amyloid PET scans are the two most common. And so we do that. And if all those things line up, then we've got the perfect person to talk to about all the nuances of this and let them, as Armin said, decide if this is a good deal for them to move forward.
Dr. Magamian, given these medications are for patients in the early stages of dementia, what strategies do you use to streamline the process for assessing eligibility? And Dr. Schultz, I caught his mention of people arrive too late. So
yeah, I mean, I think that's a really
welcome the calls to action for primary care you can offer too.
Yeah, totally. It's a really good point. I think we should just define what we mean by early stage, right? So as Alzheimer's disease progresses, it starts as just some symptoms of memory change. That's what we call the mild cognitive impairment stage. Typically, that in that mild cognitive impairment, people will have some symptoms of memory change. We may detect, as Paul said, some changes on some of these quizzes, but those patients are functioning well. They may be more reliant on lists and reminders, but they're able to adapt around their memory symptoms. That's mild cognitive impairment. Then people transition into a dementia stage, and dementia is now at the time where patients have memory symptoms that they're no longer able to adapt around, where there now is a functional consequence to these symptoms. In the mild stages, patients need help with more complex activities, typically medication management, calendar management, finances, medications, I might have said, driving. They start to have troubles with driving, but they're taking care of all of their own self-care. Often they can live independently, maybe with a little bit of help from some family and friends. And then there's the later stages of the disease, moderate and severe dementia, where patients start needing help with activities of daily living. So daily care, prompting for bathing, changing of clothing, and then full dependence in the severe stages. So when we say early stage disease, it's inclusive of that mild cognitive impairment to mild dementia stage of disease. And that's really what we're talking about with treatment of with these amyloid antibodies, because that's where amyloid is driving the disease more. As Paul said, the disease pathology kind of changes in the later stages, and the contribution of amyloid is not as significant in those later stages. And so it's not indicated for those later stages, but indicated in the earlier stages. And what's important to note is that even earlier within earlier is better. So mild cognitive impairment stage patients tend to do better, which just makes sense, right? If we're not reversing what's already happening and slowing it down, you want to slow from the earliest standpoint. You don't want to wait till things get worse before we intervene. Now, what we've been doing to kind of get at your question specifically of streamlining care is it's at very different levels. I think one of the things we do is talk right here to the public and really increase awareness. I want people, if they're feeling these symptoms, to talk to their primary care, push the primary care to think about this. We work really closely with the primary care so that they don't say, oh, those word finding difficulties, don't worry about it. That little bit of forgetfulness, I have that too, don't worry about it. But to give them an option to refer to either general neurology or subspecialty neurology, start doing some cognitive assessments, start that workup. But I think for primary care, it's about awareness of what's going on, patients to push them a little bit, and also giving primary care a pathway of sending people. What we've noticed is that if primary care knows where to send somebody, they'll do it. If they don't know what to do with the problem, they tend not to act on it. As far as what we're doing here in our center, all that testing that Dr. Schultz brought up, we used to kind of do it piecemeal, get an MRI, get some testing, get an amyloid PET, get some blood work. But because time is brain, we've really condensed that down and get almost all of that in most people when we have a high index of suspicion for Alzheimer's disease up front, because we don't want to have this thing go down another 6 months while we're kind of chasing all this testing. So we've really done that. We've hired a lot. We've, trying to staff up. I think there's a great role here for a team approach to this care. This is a pretty protocolized process, and obviously we need to have physicians overseeing it, but we've had great success with nurse practitioners here. So we're working as a team to try to really streamline the evaluations, getting people this testing as soon as possible, working with physicians, nurse practitioners to get the systems greased up, improving access to infusion. I think getting infusion locally is really important too. So we live in a large geographic system, and making sure that patients don't have to drive 2 hours to get their infusions. We've been working hard as a healthcare system to improve accessibility of the day-to-day treatments for these patients as well.
Great. Dr. Schultz, Dr. Magamian mentioned a few things they're doing to address accessibility, but how do you address potential barriers to patient access related to eligibility criteria, diagnostic testing, particularly for diverse and underserved populations?
Yeah, no, all of his points were really good. And it's always interesting to listen to another investigator and say, oh, yeah, that's exactly where we've ended up. Yeah, I think we end up spending a lot of time helping people qualify for the meds through various things. Some people don't have Medicare or Medicaid yet. We help them fill out stuff. We get them in touch with social workers. Sometimes I have to get attorneys involved who know the process that I don't know. We fill out forms for Eisai and Lilly. Those are the two manufacturers of the drugs we've been talking about. They have reduced cost form assistance for the drugs. So we fill out all of that stuff to try to help get people on the medications. And as Armin said, we've really shortened the workup. It used to take six months or something, and now we know 6 months is 6 months of brain being lost literally. And so we've really shortened the workup to a few weeks. The longest thing now is still insurance approval, but if it's straight Medicare, it's often just a couple weeks. If it's someone else, it might be a little bit longer, but we've really compressed the whole workup to get people going on these medications as soon as possible. Mm-hmm.
Terrific. Dr. Magamian, what are some potential side effects of the medications, and how does your team monitor treatment effectiveness and for those side effects?
Yeah, great question. We've talked a lot about the pluses of treatment. We should talk about the minuses and potential downsides. I should have quoted before, when we're talking about this disease modifying effect, typically on average, we're seeing about a 30% slowing in the progression of the disease. And that's sort of continued over about a 3 to 4 year period, as I said. So, after 4 years of treatment, that's saving somebody about a year of time, right? So that they're 1 year less progressed than they would have been otherwise, which again, I think is very meaningful. When I think about the side effects, I kind of break that into two parts. I think there's one aspect of not just the side effects, but the logistics of treatment. These are cumbersome treatments. They are all IV, right? So they're not pills. They are medications that are delivered through an IV, typically over 30 to 60 minutes. And they're frequent. Lecanemab is every 2 weeks. Donanemab is every 4 weeks. And typically people are on that for 18 months. So that's 18 to 36 infusions. And that is a lot of cumbersomeness. Paul has talked a lot about getting them onto the treatment, but even once they're on the treatment, it's a commitment to getting them to get these infusions. And then the other piece is monitoring them while they're on treatment for the side effects. And the main side effects that we see, one is an infusion-related reaction. So anytime you're getting an infusion into your body, you can have infusion-related reactions. Typically, this is like getting a vaccine. You feel some chills or fatigue after your first couple of infusions. In my experience, this has not been a major problem. We'll give people a Tylenol and maybe an antihistamine like cetirizine beforehand. But we do keep people in the infusion center afterwards, their first couple of infusions, to make sure they don't have a more severe allergic reaction like anaphylaxis. Again, I think the infusion reactions are entirely manageable and not a major deal. What is a more significant side effect, or potentially more significant side effect, is this side effect called ARIA, A-R-I-A. It stands for amyloid-related imaging abnormalities, which is a big mouthful, which is why we call it ARIA. And what this is that, as Paul had mentioned, we are inducing the body's immune system to bind to amyloid and remove it from the brain. And this can lead to overactivation of the immune system, which can lead to swelling that happens in the brain. And amyloid can be in blood vessels. And so sometimes that leads to bleeding that happens in the brain. So that sounds very, very scary. And if people read about these therapies, you hear about brain bleeding and brain swelling, but it's important to put it into the appropriate context. So when we think about ARIA, not everybody gets it. On average, around 20% of people may get it. That differs between the medications and how the medications are given. But about 20% of people will have one of those side effects, either the swelling, the bleeding, or sometimes both. But the majority of those people, 75% of people that get it, only get it as evident on imaging, on pictures. They feel nothing. All right. So it's an asymptomatic side effect of the medication clearing the amyloid from the brain. Of those 25% of people that feel the side effect, again, 20%, 25% of that. So you're kind of working down this funnel. But of those that get this side effect, it's transient symptoms: headache, nausea, dizziness, vision changes, walking changes, confusion, that will resolve over the course of weeks if we hold the medication. Rarely, probably less than 0.5%, will people develop these bigger bleeds that then lead to more permanent neurologic deficits. And there are other rare side effects like seizures, and people have required hospitalization. But this is less than 1% of the overall population of people that are treated. So I use this idea of a funnel where you have all these people that are treated, a subset develop the side effect, a subset of people feel it's a side effect, and then a subset of that have a significant side effect that can lead to permanent problems. But we actually have a lot of tools to individualize the risk before we even start people. That includes this ApoE genotype test, and people can kind of be in low, medium, or high risk for treatment. We also stratify risk based on an MRI. If people have features that make us concerned, we probably wouldn't give the medication. And then once people are on treatment, we can monitor them with MRIs. So we can catch this ARIA side effect before it becomes a big problem. There's slight differences between how we monitor people on treatment based on the medication, but this ARIA side effect is really in that first 6 months of treatment. So all these monitoring MRIs are stacked within those first 6 months of treatment, even within the first 1 to 3 months of treatment, and then typically 1 at 6 months of treatment. Again, details matter a little bit, or differ between the two different medications, but we can monitor for people for that. If they have this asymptomatic side effect, typically we'll hold for a month, repeat another MRI, it will get better, and we can resume treatment safely in patients. So we do have these ability to monitor and watch people, and people do recover. There are other factors that we think about for patient safety. Paul already mentioned that we don't recommend this for people on anticoagulants, blood thinners, Coumadin, rivaroxaban, apixaban. So if they're not on it, they shouldn't be on it beforehand. They shouldn't start it once they're on treatment. And then the other thing is that in the unlikely circumstance of a patient having a stroke, we also don't recommend that they receive IV blood medications that break up blood clots, called thrombolytics, because sometimes this ARIA can look like a stroke and they may have had a little bleed, and then we give them a medicine that breaks up a blood clot and that causes a big bleed. So no blood thinners and no medicines that break up blood clots. So I talked a lot there. I think that the message that I have for patients is we have to appropriately contextualize these symptoms. We want people these side effects, and we want people to be aware of the potential risk as well as the potential benefit. My clinical practice in treating patients is, and we've treated over 300 in this clinic, and as a health system, over 600. The ARIA side effect, once appropriately pre-selected, right, for patient selection, once the systems are in place to monitor people in coordination with the neurology office and the infusion center and radiology, we can safely administer these medications, and they are tolerable for patients. And this ARIA side effect is entirely manageable in my clinical practice. And that was an open question beforehand, but I think the consensus across the country, as well as what we see just in our own clinical practice, is that ARIA is manageable when the appropriate safeguards are in place.
Great, thank you. And you answered my follow-up question was going to be, once you hold the treatment, can you restart it? But you said that you can. When you have those symptoms, hold the
Yeah, I mean, not
medication that you
everybody
usually
gets not everybody gets restarted. It is always a question and an open debate. Not a debate. It's this is a conversation, right? It's a conversation whether people should get started, and it's a conversation if patients should get restarted afterwards. The majority of people we've gotten restarted have done fine. And it's, again, always this open conversation for what is in the patient's best interest.
Great, thank you. I'd like to hear from you on this next question. And Dr. Schultz, I'll start with you. What are some common misconceptions about the new treatment that you've had to address with patients and their care partners? And if I could just add to that too, and how about your colleagues, your physician colleagues who might be your potential referral sources?
Oh, yeah.
I'd love to hear about those as well.
Yeah, and I'm just gonna dovetail on what Armin said, because those are exactly the points that get people worried. People come in holding the New York Times article that says there's brain bleeds, and I mean, if I thought about taking a drug that caused brain bleeds, I'd be understandably very worried. And it's not just the patients, as you alluded to. I really have to talk to my neurology colleagues a lot, and then everybody who refers to us, primary care, geriatrics, etc. They all have to feel comfortable to want to refer their patient to the neurologist. And then a lot of neurologists refer to those of us that specialize in dementia because we've gotten used to using the medications. What I do is I literally bring up on my screen in clinic examples of microhemorrhages and show them. And I say, see that little black dot there? That's what we're talking about. And there's an artifact that makes them look bigger than they are, even though they're only 1 millimeter. And I tell people, this is what it looks like. Armand and I were at a meeting just recently, and I said, for the most part, people don't get any symptoms as far as I can tell. And Armand said, none. And I agree. We really don't see any symptoms from these microbleeds. Thank God. And part of it is we've gotten used to who to give the drug to and who not to give it. And if you get more than a certain number of microbleeds, we don't give it. So the point, though, is that I tell people all of these details and let them see them. And that's the little guy we're going to watch for. And if you get more than 10, I'm going to call you and say, we have to stop. And you're going to say, what are you talking about? I got no symptoms. And I'm going to say, yeah, but we know from safety's sake that's a criteria to stop. So brain bleeds sound terrible, but they're really very manageable. I believe in this day and age, we've learned 10 different things to do now to make it safe. And the second one, as Armin said, is brain inflammation. That sounds really bad. Inflammation, I mean, you don't want that. It sounds like pneumonia or something. And it is. But, remember what I said at the beginning, that these antibodies attached to amyloid plaques, they turn on your immune system. That's inflammation. So we actually want inflammation going on. at a low level all the time. That's how we get rid of the plaques. But some people's immune systems are very vigorous in their response. And also, some people have amyloid in the blood vessels of the brain. And that combination of things causes inflammation we can see on an MRI. It's shocking that most of the time people don't have any symptoms from it. As Armand said, we detect it now 85% of the time before there's even a symptom. And that's something we've learned. Years ago, we used to just keep giving the drugs and people would get more and more symptoms. Now we've learned this is what it is. Stop the infusions, let it calm down, and then we can start again. Interestingly, when people have that ARIA, if you do an amyloid PET scan right after that, all the amyloid is gone. I mean, they really got rid of it through the inflammatory process that we want. We just don't want the inflammatory process to be so vigorous that we see it and so vigorous that people have a symptom. The electricity flows in our brain, through wires that are covered, insulated, and they use chemicals to transmit the information. So when there's edema, swelling, inflammation, the flow of current is disrupted. So someone can come in with a weak arm because of the conduction being temporarily disrupted. Thank goodness it goes away when the swelling goes down. But the point is that there are symptoms, and we've learned to have very few symptoms now by detecting this stuff early. And we give people a handout that says, if you have these symptoms, we're going to want to see you, we're going to want to talk to you. And I show people in clinic, I show people on the scan, this is what it looks like. And if I call you and say you've got inflammation, it's because that's what I'm seeing on you. And we're going to stop until things get better. So to finish up the answer here, Jennifer, I want to say that it's been difficult to get people around the world, also colleagues, even dementia specialists, to buy into this because of the concern about brain bleeds and inflammation. I just a few weeks ago, I think it was the uh, National Health Service in England voted not to offer these medications to MCI people in England. So there's a whole country there that has people going along with MCI progressing without any disease modifying therapy. It's a real, you know, it, it hurts my heart to hear that because we have all worked a long time to develop these meds and we've got them, and to not be on them is a real shame. But and I'm sure Armand's the same way. I've given talks to people in Germany from my office here, Japan, China, trying to let other people know about what's going on here. And a lot of them weren't involved in the trials, so they don't have a good personal sense about what it's like. But if you're involved in the studies, and now for 2 years we've been giving these as standard of care in the United States, we've all been doing it to hundreds of people. Well, you see all the things that come up, and you deal with it, and you learn to manage them and feel comfortable with it. But for folks around the world that haven't seen it, haven't tried it out, it remains scary. And there are entire countries of the world that aren't offering these treatments at this time.
It's a shame that the patients that live there don't have the choice to make the choice themselves with their provider. Dr. Mogami, I'm going to ask you the same question. What common misconceptions have you had to address with your patients, their care partners, and your colleagues?
Yeah, I mean, I think starting with the patients, it's the misconception that there's nothing to do about it, right? So again, kudos to the GSA for bringing this forum up and improving early detection and knowledge about there are things to do. So I think that's the biggest misconception with patients. I agree. There has been a lot of concern about the side effects of these medications as well as the efficacy of these medications. And I think we have to contextualize that in this. There's been a lot of failures in Alzheimer's disease trials. And actually, I don't even like the word failures. There's been a lot of negative trials, meaning that we tried things that didn't work, but we learn a lot over time. There's been 20 or 30 years of these different medications, different ways of doing it, vaccines, different antibodies, and we built a knowledge base. And we improved upon these treatments. And just because things didn't work before doesn't mean that they don't work now. We've learned a lot. We've learned that we have to prove that people have this pathology in their brain before we give it, which it's almost ridiculous to say that, but there were many people in some of these early trials that didn't actually have the disease that we were trying to treat them for. So we got better at figuring out how to pick people for these trials. We realized that amyloid is more of an early pathology, so we got to give it earlier. So finding the right people, giving it earlier, finding how to better stratify the patients so that we don't expose patients that are high risk to these medications. All of those things have happened where we've now actually seen the effect. So as far as the efficacy, I wish it was better, right? But it is a real efficacy. It's not a cure. It's not a stopping of progression, but it is a real effect at keeping people in an earlier stage. And we have to get this ball rolling so that we can figure out how to even get it better. And that will happen. This will be a foundational therapy. Hopefully we give it earlier and maybe even earlier than we're giving it now. Those trials are being done now. And there's going to be new therapies that come out that either refine this and get it even safer, or other therapies on top of that make it even more efficacious. So physicians are a cautious bunch, and there's been this concern about brain bleeding and brain swelling, but it is absolutely, I think, manageable. And as we have had some of these vanguards like Paul and myself of pushing this field forward, we're better able to bring physicians on board as they're seeing patients doing well on these therapies. The best referral I get is when I see a patient, I get them onto therapy, I send them back to, or not send them back, but they go back to their primary care doctor. They see that they're doing really well. I'm going to be getting a lot more referrals from those primary care doctors because they're seeing actually these patients they're doing great. And, we've had patients on therapy for 2 years now clinically, and they haven't changed. And that's super exciting. And that's encouraging. I didn't answer the question before about monitoring efficacy. Really hard in an individual patient to say, is it working or not? We can see the amyloid go away, but how much that meant for that patient as far as the clinical status, hard to determine in the individual patients. But these were well done clinical trials that demonstrate the efficacy. And I think the greatest thing about having two medications is that these medicines are similar but different. And trials were done differently in completely different people, but basically show the exact same result. And that is, from a scientific standpoint, very encouraging, because it's not some statistical aberration about why people recovered or not. You're seeing repeated evidence that these medications are having this benefit of slowing the early disease down, which is very encouraging. So again, long-winded answer, but really to say that there are these misconceptions. I think the field is moving forward, and it's going to be through practice and seeing that it works and disseminating good information, just like you guys are doing right now.
Great. Okay. Well, before we take some questions from our audience, I have one last question for you. And I want to hear from both of you. What excites you around these new therapies and other recent developments for people with cognitive impairment?
Yeah.
Dr. Schultz, go ahead.
Jennifer, this is a total game changer, and I can't emphasize that enough. I finished med school in '84. We didn't know what amyloid was then. As was mentioned by Armin, we spent 38 years of negative trials, which were really honing our investigations till we finally got some that are positive. And to have something that works even a bit then tells us we're on the right pathway. I was at a meeting 8 years ago when one of the anti-amyloid drugs did not work, and half of the neurologists who specialize in dementia at the table, there was about a dozen of us, half of them voted amyloid wasn't involved in Alzheimer's. Because if amyloid was involved, the drug would have worked. And it turned out we were just wrong. We had to modify the drugs 10 different ways. I won't bore you with those in order to make them work. And now that they work a bit, we're looking for better ones. And we've also gone beyond that now. We're real excited and jazzed up by this finding. Amyloid, as I mentioned, is the first step, but then there's tau, deposition, inflammation, vascular disease. We have trials going on for each of those now. And we're praying that in a couple years we can say, yeah, we're going to put you on anti-amyloid and anti-tau or anti-inflammation, get better efficacy out of it. And even more than all that, as Armin just mentioned, we're now going back to people with no symptoms and saying, hey, they've got amyloid in the brain. Maybe once we see them, because the process has been going on for 20 years in the brain, maybe we can affect it but not stop it. But maybe if we go earlier, we could have a bigger impact. So there's a lot of excitement right now. We've got 4 trials, I'm sure Armin does also, of pre-symptomatic people with no symptoms coming in. We're giving them drugs, we're getting rid of amyloid from their brain, and we're praying that that reduces their risk of getting Alzheimer's disease.
That's terrific. Dr.
I
Magamian,
completely agree. I mean,
same question.
everything. Sorry, I'm going to pop in. Did you have? Do you want to? You were going to repeat the
Nope,
question.
same question for you.
Yeah,
Nope.
I completely agree with Paul. This is exciting because now we've demonstrated we can do something about the disease. 10, 15 years ago, pharmaceutical companies were all leaving Alzheimer's disease. They were sort of like throwing their hands up. Large companies gave up. But now we've proven we can modify it. And that's a really, really important first step. And there was this apathy from patients and from doctors and from pharmaceutical companies that it's just the nut was too hard to crack. But we've cracked it open a little bit, and now we're going to crack it even further. I'm very excited about these pre-symptomatic treatment of patients. I would anticipate that this is going to have even greater efficacy, and then that the combination therapy towards the future, just like, the themes of medicine are very consistent. In cancer, in vascular disease, and in Alzheimer's disease, the earlier we intervene, the better. The other very consistent theme is that you don't get one cancer drug, you get 5. And that will happen in Alzheimer's disease. We're just like 5 decades behind everybody else in vascular disease and oncology, but we're, slow. It's a harder disease, and we're going to catch up. But earlier and multimodal, multiple different types of treatments is going to be the future. But the first step of knowing we can do something about this disease and slowing it down is so, so exciting.
Great. Thank you both for such a great discussion. This has been a joy for me to see the excitement that you both have for this field and this incredible step forward for people with Alzheimer's. It's wonderful. We've got some attendee questions, so we'll spend our last few minutes here, and I'll invite both of you to chime in on any of these questions. The first that I'd like to offer is not everyone who has a diagnosis of MCI develops Alzheimer's disease. Can you differentiate between those who will and those who will not in your decision to offer the drug?
You want to go, Armin?
Yeah, I'll take it. Yeah, I mean, that's exactly why we do the amyloid PET scan, right? So mild cognitive impairment simply means memory symptoms that you're adapting around, and it can have many different causes, from degenerative brain disease to non-degenerative brain diseases, depression, sleep apnea, etc. So part of our job is to figure out what the cause is, and we now have this very specific test that can measure that pathology of Alzheimer's disease or one of the pathologies of Alzheimer's disease called amyloid. So many patients don't have MCI due to Alzheimer's disease, and that's why we need that test to prove it. And again, as I said before, I love giving people that negative result because it means they don't have Alzheimer's disease.
Do you have a preference on amyloid testing to qualify individuals for the disease-modifying treatments? And they list PET, CSF, blood.
Maybe I'll take this one, Armin. So with one of the 2 anti-amyloid therapies, donanemab, in the trial, we actually stopped people along the way if they no longer had amyloid plaques visible on amyloid PET scans. So at least if we're considering that drug, one thing to consider is that if we do an amyloid PET at the beginning, it gives us the option of doing it again later and seeing if we've cleared it up. The CSF is a good measure to decide someone has amyloid in the brain and that we should put them on one of the 2 treatments. But, and I don't know how you feel about this, Armin, but I don't think we really get that down to 0 because it's an ongoing process. So you can't really use the CSF to decide to stop, in my mind, whereas you can use the amyloid PET. But in terms of qualifying, whatever one's available, do it and get our patients on it. And then later on, we'll figure out how to get around the question of when to stop them.
I would agree with Paul. I mean, the wrench in that is the blood-based testing. This is all really, the blood-based testing is exciting and new. I think where it's going to be most useful is in ruling out the disease. Probably as this test gets more and more used, we'll see it even in primary care, where it'll help primary care figure out whether to send them to us or not. Now, that being said, a negative blood test doesn't mean they don't have another problem. So that's the caveat there. But I think the blood test is going to be helpful for ruling it out. I think in some circumstances, it may be enough to rule it in. And in this very sort of classic patient that has the disease, maybe they don't have access to an amyloid PET scanner because they have to drive really far. We may start to use that more and more frequently to rule in the disease and get people onto treatment. Again, it's all really new. I mean, we're talking a couple of months that these things are available. So it's shifting in the field. I just like Paul, typically are leaning towards an amyloid PET. It's a little more convenient for patients. There's no needle involved, and it's a really gold standard test. So that's kind of where I'm leaning. But in that early qualification, definitely CSF and PET are pretty equivalent, and blood is coming up pretty soon. And we're all kind of figuring out how to use that and use it appropriately.
What advice can you give members of the primary care team or others who may be talking with older adults when someone asks them about the benefit they might receive from an anti-amyloid therapy and how therapies would change their daily life?
Yeah, I mean, at a minimum, everybody slows down, but by different amounts, depending on when we catch them. So yeah, in the trials, we quote a figure of 30% slowing because that included everybody early and not so early. But as Armin said, we both have patients who are 3 and 4 years into the medications who haven't changed as far as we can tell. We assume that those are the real early ones, and I never promise anybody that because it's hard for us to predict who that's going to be. But the point is, it can slow people down a lot. So anywhere from 30% to 100%, presumably, depending on when we catch them. So yeah, for our primary care colleagues, emphasize buying you more time with your grandkids. I have grandkids now. I would do anything to get 6 more months with them or a year more with them or whatever, maybe even longer. And those folks, that often resonates with people. Just like with cancer. If you could slow a tumor down 30%, yeah, you'd do that. I don't want to, be lost sooner than later. And it's the same here. And I think those are good points to raise with people to help them decide whether this is for them or not.
Well, speaking of primary care, I've had a couple of folks raise in the questions about the wait sometimes to get in neurology, but I wondered if there is that time waiting for an appointment, how can the primary care clinician use that time to make sure when that patient hits your door that you have the best path moving forward quickest for them? So what can primary do to get them ready?
Yeah, this is a great question. I think the answer is evolving over time. I think getting the appropriate triage of patients is really helpful, right? So if they're really wanting to get us people that are going to amyloid therapy, is really gearing that early stage patient. The later stage patients, some of those do need to come and see us. I think this is a topic for another time, but we don't want to overly focus on the amyloid therapy. There's a lot of patients with degenerative brain diseases that need our subspecialty care that we don't want to forget about. But if primary care is sort of focused on, is this a patient that we want to get on, focusing on that early stage patient, getting some initial cognitive testing like a MoCA, making sure that the other things have been ruled out, like a thyroid test, a B12. It's rarely those things, but it's good to do. I think a baseline MRI is a really helpful test to get started. The use of biomarkers in primary care, I'm a little more hesitant about. I would really hate for a patient to get this amyloid positive result and wait 4 months to see me. That's a tricky one to deal with. So I don't really advocate for that at this time. These things may evolve later. So I think those first few things can be really helpful, as the appropriate stage patient, getting those initial testing done, maybe considering the blood-based tests could be a little bit helpful for us to triage, a little bit in flux there. But that's what I would say. And also actually primary care doing a really good medication reconciliation, making sure that they're not taking Benadryl and all of these other anticholinergic medications that can impact cognition. Because at the very least, they may have Alzheimer's disease, but you're going to make it worse if they're taking those medications. So I think primary care can be a great partner in getting those other medical aspects taken care of so that we can really focus on getting these eligible patients onto treatment.
Mhm.
Right. And could you speak a little bit about genetic testing and kind of where that fits in with suitability for determining treatments?
Yeah, as Armin mentioned earlier, there's one gene that's associated with about 60% of people with Alzheimer's. So it's not a causal gene in the sense that not everybody with the gene gets it, but it is a risk factor. And not only is it a risk factor for Alzheimer's, but it's also a risk for amyloid deposition in the blood vessels, which means that they're at higher risk for the ARIA E and H. So I get the test because I want to be able to tell someone specifically, you're in the 5% risk, 10% risk, 20% risk, 50% risk. And then they can use that information as part of their decision making about how they feel about this. The people with the 50% risk of ARIA, I have to tell you, they often go for it anyway. I almost never get someone turn it down because they got a gene from both sides of the family usually, and they've seen what Alzheimer's is like, and they're very highly motivated to try to prevent that. And so they go for it anyway. But this way they know, hey, you get a little headache, you got to tell me about that. You got a little this, a little that, you got to tell me about it. We're going to watch you like a hawk. And that's where the genetic testing helps me a lot, help people with the treatment.
Well, we are just 1 minute before the hour, so I just want to again offer my sincere thanks, first of all, for the wonderful work that you gentlemen do. It's so wonderful to hear and see the passion that for what you do come alive as you speak about it. I really am grateful as a nurse and a daughter and a patient and all of those things. So thank you so much for your great work and for taking your time out of your very busy schedules to be here with us today. We really appreciate your support of this program. And again, I want to acknowledge the Alzheimer's Association who helped us connect with you and supported us in developing these programs, and to Lilly for supporting us to put them on. Thank you both so very much for joining us.
Thank you for hosting us, and thank you for your advocacy for our patients.
Thank you very much. Real pleasure.
Thanks.